rheumatic diseases. We all know that rheumatic diseases are far more commoner in women than in men. Whether it's a nature's gender bias, estrogens that on one hand render osteoprotection and protection against cardiovascular diseases, they do that at a price in the form of autoimmune rheumatic diseases. Another challenge is pregnancy, which itself and its management is really challenging. With due respect, I invite our chairperson, Dr. Iracon from Mumbai. Ma'am is a teacher and well known for osteoporosis awareness through International Osteoporosis Foundation in Geneva. Over to you, ma'am.
Good morning, everybody. We'll start with our first lecture, that is Nature's Genders Bias and Autoimmunity, X chromosome or estrogen, by Dr. Hal Joyphilip, USA. She's not coming.
But I would like to tell you about the sex bias and autoimmune disease and what we've been doing to look into this problem. Of course, autoimmune diseases, especially the ones I'm most interested in, and all of us are most interested in, are highly sex biased. This includes lupus, systemic sclerosis, and Sjogren's, but also includes rheumatoid arthritis, which is less sex biased than these diseases, which have almost a 90% sex bias. And at least for lupus, there's not much evidence of sex hormones being involved. There's many cross-sectional studies looking at sex hormones, and these studies find sex hormones in lupus patients are abnormal. The problem is, of course, these are comparisons to healthy controls, and chronic illness affects sex hormones. And these studies are after some long duration of lupus. In men with lupus who were tested at diagnosis of lupus, testosterone levels were the same among those men as there were in healthy controls. And in both sexes of lupus, there's only one study I've ever been able to find with a disease control group, and this study used congestive heart failure as a control group and found no differences in sex hormones between lupus and matched individuals with congestive heart failure. So I think, although the data are limited, I think that the interpretation of these data, at least in lupus, is that sex hormone abnormalities are caused by the disease, not the cause of the disease. And so I'd like to remind you about some sex chromosome aneuploidies, which you don't think about very often, probably, although I think about them all the time these days. And that one is Klinefelter's, which is 47XXY, and that's about 1 in 500 live male births. But these men are only diagnosed in life about 20% of the time. 47XXX is about 1 in 1,000 live female births, and those women are well and are undiagnosed. There's nothing to diagnose because nothing's wrong with them. Turner syndrome is 45XO. It was described by Henry Turner about 200 meters from where I'm sitting in Oklahoma City right now in 1930s, 1934, and it's about 1 in 2,500 live female births, and virtually everyone with Turner's is diagnosed. And we have looked at Klinefelter syndrome among large samples of patients with these diseases, and you see here 67 men with scleroderma, 3 had Klinefelter's. Also increased in dermatomyositis and polymyositis. Our original observations were in lupus and Sjogren's, again, quite increased, especially compared to controls, but we did not find an increase in 47 XXY Klinefelter syndrome in rheumatoid arthritis. We also didn't find it in primary biliary cholangitis. And we just published the data here in the bottom in just a few weeks ago concerning scleroderma and dermatomyositis, which have this abnormality. We also looked at 47XXX in these cohorts. We didn't have very many women with scleroderma, so we found none, but that may be just a sampling error. Again, in polymyositis, Sjogren's, lupus, we find increases of 47XXX among the women, but we don't find this increase in other sex-biased diseases primary biliary cholangitis or rheumatoid arthritis. And so I just remind you a little bit of X chromosome biology, again, that you probably don't think about very often, but all X chromosomes in any cell, except for one, in any given cell are inactivated. This is an active process involving an RNA called exist. But it's not an all or none phenomenon. In some cells, up to 20% of genes, and in almost every cell, sort of 10 to 15% of genes escape X inactivation. And this turned out to be especially common on distal XP. And these data were mostly in fibroblasts until recently, but now there's very nice data in many cell types that much of distal XP escapes inactivation. We found these interesting patients, very highly unique patients, a Turner syndrome with lupus, in which the patient had one normal X chromosome and then a isolated P arm and no second Q arm. So this patient has two P's, just like a man might have. And here's a Sjogren's patient with 47 triple X, except it's only partial triplication. One normal X chromosome, one X chromosome with a distal XP just stuck on the end of their other X chromosomes, so 3 P arms. And this patient also had 3 P arms, another Sjogren's patient. One X chromosome is normal. This X chromosome has 1 P arm, an inverted section of XQ, and then a third XP arm here. So 2 P arms on this chromosome, 1 on the other chromosome. So this made us think about distal XP as a site where genes might lie that mediate this dose effect of the X chromosome on the sex bias of lupus. And we got interested in a gene called CXORF21 that now has a new name, but we got interested because it contains a lupus risk allele. It routinely escapes X inactivation, and it was known to physically interact with another lupus risk gene that has a lupus risk allele, and that's SCLC, soluble carrier protein 15A4. And they come together physically on the surface of the endolysosome. This gene is now called TASL, and it's known to have sex-biased expression that's biallelic, and we showed this. Here's its expression in lupus women, lupus men, and normal healthy controls. And even among the men, you see here that the lupus men express it much higher than the normal men. And this, we think, is due to the fact that these lupus men are much more likely to be hemizygous for the risk allele, which changes expression. And so we got to looking at this, what TASL does, which really wasn't known before we started looking into it. And when we knocked it down with CRISPR-Cas, it changed lysosomal pH in a way that would make TLR7 signaling less effective and less robust because it raises lysosomal pH. And then we looked at TLR7 with the signaling. So this is taking female cells and stimulating them with a known TLR7 agonist. And we find, when we did that, when we knocked down TASL, we find big reductions down to vehicle, to control levels of interferon, as well as TNF-alpha and IL-6. So TASL is part of the system, is involved in TLR7 signaling, as is soluble carrier protein 15A4, its binding partner. And we noticed that TASL has a motif of a short-chain dehydrogenase, and our recent data really show that it does have dehydrogenase activity, and it converts NADPH to NADP in this assay. And here's how we kind of put this together. We have soluble carrier protein SLC15A4, which binds TASL, or they bind each other. This is an amino acid and a hydrogen ion pump, which changes or regulates lysosomal pH, which is critical for TLR7 signaling. If you knock out SLC15A4, that ameliorates mirroring lupus. If you knock it down, there's no TLR7 signaling, just like TASL, and it increases lysosomal pH, similar to TASL also. So TASL is probably supplying, it is a dehydrogenase that's supplying hydrogen ions to be pumped into lysosome, alter lysosomal pH such that TLR7 signaling produces these cytokines, which are, especially interferon, is critical for the pathogenesis of lupus. This has all been prosecuted in my laboratory by Valerie Lewis and Christina Brooksfart, and is a collaboration with SWAP and NAT. We were interested in genetics of these since they both have lupus risk alleles, we're interested in the genetics of this. Of course, lupus is an inherited disease, but we've done very large numbers now of genome-wide association studies and meta-analysis, but still, all these put together only explain about a third of lupus inheritability. So there's lots of missing genetics. We wonder whether there might be some synergism between these two genes, and in fact, that's what we found. We looked at men. Who had a risk allele in soluble carrier protein 15A4 and in tassel, that they were much more likely to have lupus than men who did not have a risk allele in both. Of course, men are homozygous for tassel because it's on the X chromosome. So there's a very powerful statistically, and gave an odds ratio of 4.1. Individually, each one of these genes only has an odds ratio, a risk ratio of about 1.1 or 1.2. So this 4.1 is much higher than additive or multiplicative genetics. So we think there is synergism between these two genes that are critically involved in TLR7 signaling. And this may be in some of the missing genetics of lupus is in this kind of synergism. So here's how we put it all together. Again, CXOR21, tassel is critical for TLR7 signaling. It's critical for lysosomal pH. It has this dihydrogenase activity and has this genetic interaction with its binding partner, SLC15A4, and in part, at least, tassel, which is on the X chromosome, may drive the this gene dose effect of the X chromosome for the sex bias in lupus. And this is I just put up my acknowledgement slide. Valerie Lewis, whose picture you see there, prosecuted most of this work in my laboratory, and our funding agencies, our collaborators around the world, as well as in Oklahoma. And I'm happy to try to answer any questions. Thank you.
Thank you, Dr. Scholl. Since it's a recorded video, do we have a question answer here? No. I don't think so. I think so. I'll call the next lecture is on managing critical pregnancy complications in women with rheumatic diseases. I invite Dr. Rohini Samant. She's a consultant rheumatologist at Hinduja Hospital, Mumbai. Over to you, Dr. Rohini.
Good morning. I think it's the last day and it's obvious from the dwindling crowd. But I mean, whoever is there, let's have some interaction also. So the managing critical pregnancy complications in women with rheumatic musculoskeletal disease. This is my topic. Now, there's little time, so I'll be focusing predominantly on lupus pregnancy. Now, this is the latest RCNA on lupus, on pregnancy in rheumatic disease. And in the same issue, there are two different perspectives as far as pregnancy and lupus goes. One of which is from a study which included patients with lupus who had relatively mild disease when they got pregnant. And this is about 700 pregnant women. And I'm focusing on the maternal outcomes here. And they found that less than 15% of patients had, had milder flares, and only 3% had severe lupus flares during pregnancy. However, there is another author who speaks about lupus pregnancies in multiple studies in the general population. And they say that they conclude that despite advances in SLE management and pregnancy outcomes, multiple studies have shown an increased rate of pregnancy loss, preeclampsia, eclampsia, maternal death, and cesarean section delivery in women with SLE compared with the general population. Now, how do we sort of try and make sense of these? I think one of the things that strikes me or hits me actually when I will speak about this case is the utter unpredictability of pregnancy in lupus, particularly if the disease is mildly or more severely active. So I'll start off with the case. This is a 25-year-old woman who came with fever, joint pains and seizures, and she was admitted to a private hospital, had a low hemoglobin and a raised creatinine. An ANA was found to be positive, and she had seizures, and the MRI showed some white matter intensities in multiple areas of the brain. She was only treated with anticonvulsants and steroids at 60 milligrams of prednisone. Within a month, she developed bilateral lower limb swelling, oliguria, and oral ulcers, and that's when she got admitted to our hospital. She had a low hemoglobin again as earlier. The BCT, the Coombs test was VT positive, indirect was negative, APLA workup was negative, and the ANA blot was dsDNA positive and the nucleosome 2+ positive. Her creatinine was a little lower than earlier, but at 2.6, and she had 2.4 grams of protein loss. A renal biopsy was done, which showed a class 4 lupus nephritis with the activity index of 19/24 and a 4/12 chronicity index. So this is the fibrocellular crescent, and this is the viral lesion. The story continues. She was nulliparous. She was treated with, because of the aggressive disease, she was treated with only 3 cycles of cyclophosphamide being nulliparous, followed by mycophenolate mofetil at 3 grams per day with hydroxychloroquine. The creatinine at 6 months was 2.3. The C3 was still low, although more than earlier, and the urine protein was 4.2 grams. She was very keen to get pregnant. She did not believe in the treatment. She stopped treatment after 6 months. And after this, she was completely off the radar for the next 1.5 years. And she was completely asymptomatic during this period. She comes back to us in September 21 saying that she wants to get pregnant. She is asymptomatic. She had mild hypertension, which was controlled with amlodipine. Her creatinine surprisingly was 1.7, lower than earlier. Her C3, C4 were fairly normal, and the urine protein creatinine ratio was 0.74. So, knowing her non-compliance, and we advised her to get pregnant only after at least an observation period of 1 year with treatment, and she was started with on hydroxychloroquine with azathioprine with the TPMT mutation analysis done. And she had no cytopenia after a month of azathioprine, 75 milligrams. But she was desperate to get pregnant, and she conceived in November 21. Within a week of pregnancy, she comes back to us with excruciating joint pain preceded by fever for 2 days and swelling. And her blood pressure was normal. She had severe arthritis. Her hemoglobin had dropped to 5.5. Her platelets were 187 when she got admitted. Within 3 days, they dropped to 87,000. We looked for mass, so ferritin was normal. We looked for a TMA, peripheral smear-poshistocytes was negative. APLA workup was negative. The C3 also dropped within 4 days from 93 to 43. Her creatinine was 1.9. She tested positive for chikungunya, PCR. She was just 2-3 days of the fever, and the IgM was negative. Now, because of the drop in hemoglobin, the drop in the C3, she was treated and she had excruciating joint pain. She was treated with solumedrol pulses, followed by steroids. And azathioprine was initially stopped, but later again started at 50 milligrams per day, and aspirin and hydroxychloroquine were continued. March 20, she had a follow-up in between. She was reasonably all right in Feb with a platelet count of about 60,000. But she comes to us at 18 weeks of pregnancy in March with no oliguria but bilateral lower limb swelling. And her blood pressure has shot up now to 150/100. Her platelets are 24,000. Her LDH is raised a little at 350. We again repeat her peripheral smear, which is negative. We look at her liver function. Early health is a possibility, HELLP, and the liver enzymes were normal. The coagulation profile was normal. Creatinine had started to rise. The uric acid was 8.8, proportionate to the creatinine. And the UPCR now was 8 grams. The C3 was low at 57.
She was diagnosed as a flare of lupus complicated by early preeclampsia, very incomplete health. There was no liver enzyme elevation, but there was this persistence of platelet drop, anemia, without schistocytes, so without a TMA picture. We added labetalol and we gave her pulses of steroids. She continued to have a rise in creatinine to 3.1, had persistent thrombocytopenia. And the obstetric ultrasound also gave a very guarded prognosis. She was advised termination of pregnancy, and plasmapheresis was initiated and discussed about cyclophosphamide. She had financial constraints. She shifted to KEM Hospital, which is nearby, and the pregnancy was terminated there. However, even postpartum, she had a course which was completely not responsive to all the treatments that were tried at KEM. So she was continued with plasmapheresis, dialyzed, IVIG, rituximab. She was there for a month at KEM, but we lost her after a month. So this was the final diagnosis, lupus nephritis with a disease flare, very triggered by chikungunya and pregnancy, preeclampsia, early preeclampsia, this was only 18 weeks, very a partial health syndrome. And I wanted to discuss this case really to bring out what can happen if, the primary rule of managing a lupus pregnancy is control of disease prior to pregnancy. So if that does not happen, in this case because of the patient's insistence, we had this very, very tragic result. And so just taking you back to the 2020 guidelines for management of rheumatic disease in pregnancy. So the first dictum is, of course, assess activity in anyone considering pregnancy. This is prior to pregnancy. And if there is high disease, control the disease and only then advise the pregnancy. The second dictum is to do the antibodies which we all are aware of, the anti-Rho and the anti-LA and the antiphospholipid antibodies. So the factors which affect pregnancy outcome, and I have highlighted those which were present in our patients. The positive impact, pregnancy planning and counseling, the patient defied this. In fact, she was advised pregnancy termination even earlier, but she wasn't willing. The disease was not in remission. It was a partially sort of responder, and she had a creatinine of 1.7. She had not adhered to medication. She had active disease. She had some end organ damage. It was an unplanned pregnancy with an unplanned cessation of treatment in the past. So all these factors went against this particular pregnancy. And to bring out some more factors which have been associated with adverse maternal and fetal outcome is, of course, the presence of maternal hypertension, which our patient had, the presence of proteinuria, which our patient had, and anything above 300 to 500 is considered a risk factor for the pregnancy. An active lupus nephritis, more than 2.8 has been cited as a contraindication. But anything with above 1.4 is a relative contraindication to pregnancy. Okay? And then, of course, we are aware that severe pulmonary hypertension, advanced cardiac failure, severe restrictive lung disease, and the presence of serological factors like the triple positive antiphospholipid antibodies, anti-DSGNA bodies, again, which our patient had initially, and are risk factors. And just to look at the data, that the maximum lupus flares in pregnancy are renal and hematological, and unlike about a 10% incidence in the normal population, 30% develop preeclampsia with lupus, and of these 15% may have HELLP syndrome. So how does one manage SLE in pregnancy? Actually, there's not a lot new. Again, want to re-emphasize, it's the planning of pregnancy that is very important. And so management is, of course, very close monitoring by the obstetrician, the rheumatologist, and the nephrologist and the hematologist in our particular case. They were all in the picture. And the schedules of visits increase as the pregnancy advances. One has to monitor the counts and the urine, the creatinine, the DSGNA and the complement antibodies. and check the blood pressure. So look for preeclampsia coming early. It's mentioned that preeclampsia does occur early in our lupus patients. And of course look for the fetal echo in those who have ROLA positive, and follow it up with treatment if required. And the ultrasound done in the third trimester at every 4 weeks, and more frequent if there is a suspicion of IUGR. Low-dose aspirin has been recommended by the United States Preventive Task Force and is to be used at 12 weeks. We had started it earlier in our patient itself. Antihypertensives which are safe in pregnancy, labetalol was used in our patient. Of course, we know methyl dopa and nifedipine can be used. NSAIDs, arthritis are not to be used in the third trimester, but usually we don't tend to use NSAIDs. Hydroxychloroquine, of course, the mainstay of, or the has to be part of every lupus treatment, helps in complete heart block and also in APS. Corticosteroids, the lowest possible dose of corticosteroid should be used. It was not possible for us to use low dose steroids here. And dexamethasone, betamethasone have been advised in two contexts. One is in the prevention of heart block, if one has first degree heart block, and the second is the prevention of the allowing the lung to mature in a premature delivery between 27 to 34 weeks. Azathioprine we know are safe in pregnancy. Cyclosporin, tacrolimus. Our patient had hypertension, so cyclosporin and tacrolimus was an issue. Cyclophosphamide can be used as a salvage in the third trimester. IVIG and plasmapheresis, which we used plasmapheresis in this patient. Rituximab has been recommended so far only till conception. And of course, this last line is important, that severe refractory disease calls for early termination of pregnancy. Whether this could have been done earlier was also suggested to the patient. However, it happened in the 18th week, but despite further treatment, the patient could not be salvaged. And this is quickly to just touch upon a few points in the scleroderma pregnancy, which are a little different from the lupus pregnancy that we are familiar with. And here, these are the drugs that are safe in scleroderma pregnancy. Of course, scleroderma renal crisis occurs in only about 2% of scleroderma patients, and ACE inhibitors are recommended to be used even in the pregnancy, although they are otherwise contraindicated to salvage the kidney. Azathioprine, tacrolimus are safe for ILD, and epoprostenol. Okay, so I think I'll skip the slide on scleroderma. These are the safe drugs. The recommendation for antiphospholipid antibody in lupus or in any rheumatological disease, we are all very familiar with this, so I didn't want to spend too much time. If there is only positive antibody with no syndrome, only low-dose aspirin, with a obstetric antiphospholipid history in the past, we use low-dose aspirin with prophylactic heparin, and with a history of thrombotic APS, we use low-dose aspirin with a therapeutic heparin. So the take-home messages are, and I cannot emphasize this enough, that pregnancy planning is critical to good maternal and fetal outcomes in autoimmune rheumatic disease. I think this is the most important point that you can take from this talk. Patients have to be in a low disease state for at least 6 months prior to planning pregnancy, and a multidisciplinary team well versed with management of high-risk pregnancy is necessary to manage pregnancy complicated by flare of underlying disease or pregnancy-related complications like preeclampsia or health syndrome. So this is my final slide. We really enjoyed all the sights and smells and sounds of Indore, and this is just a thank you from the bottom of my heart to all the organizers for holding the meeting in such a place where we could have much more than only science. Thank you.
Thank you, Dr. Rohini. We can take few questions from the floor. Any questions? If there's no question, we go to the second talk. That is by Dr. Gayatri Egbote from Pune. Update on safety categorization of medications in pregnancy and lactation.
I have one question.
Yeah.
Ma'am, if suppose we detect a fetus who has first degree or second degree congenital heart block, So as we know, we can use dexamethasone. So I just wanted to know, is it recommended to continue dexamethasone until the end of the pregnancy?
The recommendation is to use it for 4 weeks.
Okay.
4 weeks from the time that you diagnose it. So that's around 16 to 20 weeks. To use it for 4 weeks. If it doesn't work, it's unlikely to work.
Yeah.
One of the things they said is that in addition to maybe prevention of a second or a third degree of heart block, they can also protect the myocardium. So
Yes.
we know that there can be congestive cardiac failure. So there is some effect on that as well. But the recommendation is for 4 weeks.
4 weeks. Okay, thank you.
Over to you, Gayatri. Thank you, Rohini.
Am I audible? Good morning, everybody. Thank you, organizers, for giving me this opportunity. It means a lot for a young rheumatologist like me to come here and speak on this diet. So, though on social media we are living in an era of women empowerment, I think our age-old problems remain the same. And one of them is pregnancy and diseases associated. So, earlier, EULAR 2016 and ACR 2020 gave us updated guidelines regarding the safety of anti-rheumatic drugs in pregnancy and lactation. But a couple of weeks ago, we had newer guidelines by BSR. Just I think on 2nd November, BSR 22 guidelines were published. So as we all know that there are chronic diseases which affect the maternal and child well-being, and few of the important diseases being inflammatory rheumatic diseases or IRDs. And this is the UK data which shows that, so this is one of the UK data which showed that around approximately 8.8 of 100,000 women died during pregnancy or during postpartum. And I assume that Indian would be much worse because MATMOT or maternal mortality in India is quite high because we are obviously rich in the data and we are rich in the diseases also. So as ma'am just pointed out, lupus does flare during pregnancy and there are diseases like rheumatoid arthritis which probably go into the remission, and diseases like Anspon could remain neutral, and it just depends on the maternal functional and physical well-being. So why did we need updated guidelines? Because as we all know that obviously there is an uncertainty regarding the rheumatic diseases in pregnancy and obviously about their treatment. So because of anxiety and that uncertainty, there is unnecessary withdrawal of anti-rheumatic drugs, and both these things lead to flare of several diseases, and that leads to worsening of maternal and fetal outcomes. So coming to one of the most important papers, I think this was just a patient-based data. There were two communities, arthritis for and creaky joint communities, and they had enrolled few females of childbearing age group. So they were asked few questions like regarding their knowledge about pregnancy and rheumatic diseases, their knowledge regarding the treatment in rheumatic diseases and their safety, etc. And obviously very few females knew about it, and these patients were from UK. Still those were well-learned females, and only 36% females felt that steroids were safe during pregnancy. Obviously, none of them felt that methotrexate, leflunomide or biologics were safe. And to our surprise, none of the females felt that even sulfasalazine was safe during pregnancy, and only 11% patients, females, felt that NSAIDs were safe during pregnancy. So obviously, there is a need to have an updated guideline. So as we all know that we have DMARDs for treating our diseases. So we have corticosteroid, hydroxychloroquine, our conventional DMARDs. We have biologics like TNF blockers, then other biologics like other than TNF blockers, and we have targeted synthetic DMARDs, etc. So coming to generic recommendations by BSR 22, obviously counseling is very important part of any disease and its treatment. So one of the most important aspects is to avoid pregnancy incompatible drugs. We need to address the risk and benefits. I'm sure we all do that in our OPD and IPD. And we have to change incompatible drugs to compatible ones. But again, very important thing is, the severe or life-threatening maternal illnesses should always take priority over the fetal outcomes. And we need to address infant immunization after their in utero exposure to biologics. Steroids should be used judiciously. And we need to discuss about paternal drug exposure and safety of conceiving. But this is not the topic today. So let's probably start with the safest drug, which is hydroxychloroquine. And there have been few antimalarials which have been used during pregnancy, and hydroxychloroquine or HCQ remains the most commonly used drug, and it remains the antimalarial of choice. But it should be used, it should be continued at dose of less than 400 mg per day, and it is quite compatible with breast milk exposure. Address ophthalmic toxicity we have been using in a dose of more than 400 mg per day. The latest guidelines did not show any increase in adverse pregnancy outcomes after HCQ exposure. Corticosteroids, everybody, even I am scared of steroids. I think rheumatologists are much more scared of steroids. But yes, prednisolone remains preferred corticosteroids in pregnancy. One needs to monitor sugar and BP during steroid usage. One important recommendation was to reduce or taper steroids as quickly as possible, probably less than 20 mg per day. Steroids are compatible with breast milk exposure. And methylprednisolone is equivalent to prednisolone in terms of placental transfer. However, methyl pulse therapy should be always a rescue therapy, and it should not be used routinely. Again, adverse pregnancy outcomes are usually due to high dose, high potency or prolonged duration of steroids, and not because of the usual dose of steroids. So, I think we all have enough knowledge about these three agents, but silver lining is the newer BSR guidelines say that methotrexate should be stopped at least a month prior or month pre-conception. Earlier guidelines said that earlier guidelines I think gave duration between 3 to 6 months. We all know that methotrexate and leflunomide are not recommended during breastfeeding. Leflunomide obviously carries a lot of theoretical risk, and those considering pregnancy should stop leflunomide immediately, and they should undergo standard cholesterol washout. We all are aware of methotrexate and leflunomide toxicity, and methotrexate is non-teratogen, and leflunomide may not be a human teratogen, but animal studies have shown otherwise. So obviously we need to stop leflunomide during pregnancy. Sulfasalazine luckily appears to be safe during pregnancy and during breastfeeding also, but the female should have enough folic acid supplementation during sulfasalazine usage. Then coming to immunosuppressive therapy, azathioprine, as ma'am also said that azathioprine is quite beneficial during pregnancy, or it is quite safe during pregnancy. There is insufficient data about calcineurin inhibitors, and most of the data has come from the transplant or organ transplant patients. Tacrolimus still remains compatible throughout the pregnancy and breastfeeding. There is less data regarding cyclosporine usage in pregnancy, and few case reports have shown that there is a trend towards low birth weight babies or shorter pregnancy duration, etc. However, it is compatible during pregnancy. When you are using calcineurin inhibitors, I think you need to monitor sugar levels, BP, and RFT and the drug levels, etc. Cyclophosphamide and mycophenolate, I think we all are scared of these drugs generally also, and when we are counseling our patients. Not we are scared, when we are counseling our patients. So these two drugs are complete, they are not recommended during pregnancy and during breastfeeding. Cyclophosphamide is non-teratogen and gonadotoxic. It should be used only when there is severe life-threatening maternal disease, and if you have unintended pregnancy while patients are on these drugs, please switch them to pregnancy compatible drugs and refer them to local experts. As I said, severe lupus nephritis or ANCA-associated vasculitis probably would take a priority over fetal outcomes. we all are aware about the cyclophosphamide embryopathy and teratogenicity about mycophenolate. So I won't get into details of that. So coming to one of the most important or burning topics of today's era, which is biologics. So as we all know, all the MAB antibodies like golimumab, adalimumab, infliximab, etc. and even the fusion protein, etanercept, they have IgG predominantly, and the placental transmission of IgG, it increases quite considerably during the 3rd trimester of pregnancy. So these 3 drugs, adalimumab, infliximab, golimumab and etanercept also, they have known placental transfer, but certolizumab, being pegylated Fab version, does not have placental transfer. So certolizumab rather is quite safe during pregnancy and during breastfeeding also. So ACR 2020 sadly just commented as a proof on the usage of TNF blockers during pregnancy, and it said that though these are compatible for infants, these all drugs should be stopped at 30 to 32 weeks. However, the newer BSR guidelines say that infliximab should be stopped at 20 weeks, adalimumab and golimumab should be stopped at 28 weeks, and etanercept should be stopped at 32 weeks. And certolizumab is compatible in all 3 trimesters. All these drugs are compatible throughout breastfeeding. But if you have, these drugs should be stopped when there is low risk of flare. When there is a risk of flare, obviously do not stop these drugs, and there is no need to switch to other drugs, other TNF blockers. Once you stop these drugs, infants can have normal vaccination schedule, but in case if you could not stop these drugs, probably you need to postpone the live vaccination schedule in infants. And as I said, these are compatible. All the TNF inhibitors are compatible during breastfeeding. Non-TNF inhibitors, I would talk about them as a group. We are mainly using rituximab. ACR 22 said that rituximab should be discontinued at conception only. It should be only used whenever there is live or organ-threatening disease, because there is a fear of neonatal cytopenia. But rituximab is compatible during breastfeeding. Sadly, when these guidelines were formed, there was very limited knowledge about other TNF, non-TNF biologics. So let's see what BSR 22 says. Sadly, again, they have very limited evidence, but they have assured us that these biologics, non-TNF biologics, are not teratogen. But there is inefficient or insufficient evidence that these are compatible with pregnancy. These should be used only when there is severe disease, and if they are used in 3rd trimester, the live vaccines in infants should be postponed, and these all drugs are compatible with breastfeeding. Coming to the hot cake of today's era, which are JAK inhibitors or small molecules, like tofacitinib, baricitinib, apremilast. Again, there is insufficient data. Even BSR 22 could not give us the proper answer. But one of the fortunate things was it says that tofacitinib or baricitinib could be stopped at 2 weeks before conception, whereas EULAR 2016 said that this should be stopped 2 months before planned conception. However, this should not be given during breastfeeding. IVIG is compatible throughout pregnancy and breastfeeding, and it is often used as a rescue therapy. Coming to the last part of the session, we are not just using DMARDs while managing rheumatic disease in pregnancy. We are also using other drugs, and these drugs are basically used to treat comorbid conditions. These are NSAIDs, conventional painkillers, low-dose aspirin, clopidogrel, anticoagulants, colchicine, dapsone, bisphosphonate, antihypertensive, pulmonary vasodilators, etc. So paracetamol should be used for intermittent use during 1st and 2nd, 3rd trimester. Codeine should be avoided in breastfeeding. Then NSAIDs, non-selective NSAIDs should be used cautiously in 1st and 2nd, 3rd trimester. COX-2 inhibitors, there is big no for their usage throughout pregnancy and during breastfeeding. Colchicine and dapsone, they appear quite safe during pregnancy and breastfeeding. Then coming to the neuromodulators, amitriptyline, gabapentin, pregabalin are quite safe. during pregnancy and during breastfeeding. However, whenever you are using gabapentin and pregabalin, please supplement the female with high dose folic acid. These antipsychotics, if you are using, you can continue, but amitriptyline, gabapentin, pregabalin are preferred neuromodulators during pregnancy for pain control. But however, if you are using antipsychotics, don't stop in postnatal period, because obviously these females are used to these drugs. Antiplatelets, as we all know that aspirin and low molecular weight heparins are our darlings, especially during APCA, SLE, etc. Clopidogrel, there is limited evidence, but however studies have shown that it is not harmful. Warfarin, big no, periconception and first trimester. You could use in exceptional cases in second or third trimester. It is compatible with breastfeeding. Fondaparinux, it is compatible in breastfeeding and in pregnancy as well. Rivaroxaban is only found to be compatible during breastfeeding amongst other direct and oral anticoagulation. Other drugs are not found to be safe during pregnancy and breastfeeding. As ma'am also said that we could use ACE inhibitors or ARBs in pressing situations only. However, this should be stopped whenever pregnancy is confirmed or in first trimester. There is only good data about enalapril during breastfeeding. I think amlodipine, nifedipine, you can use methyldopa, labetalol. They are quite safe during pregnancy. Just sildenafil, bosentan, prostacyclin. Sadly, there is no enough data about their usage during PH in pregnancy. So you need to have multidisciplinary assessment, and that should include cardiologists, pulmonologists, etc. also. There is no data about their usage during breastfeeding. Bisphosphonates should be stopped preconception as well as during pregnancy and during breastfeeding. So coming back to this paper, as I could learn or as I could see, or also as you all could have seen, mainly these UK women opted online sources for their knowledge. Then they looked at the packet information on medicines. Then probably followed by they went to pharmacies, registered nurses, or they had some WhatsApp groups, etc. So I think there is a lot of gap. There is a big gap between knowledge, the existing data, and patient's knowledge. So I think we need to take this opportunity, and we need to have future research agenda. We need to have national patient registry. We should have our own published data for the same, and our data should be prospective. It should be able to answer few burning questions like lithotripside stoppage, burning questions regarding targeted synthetic DMARD, biologics, etc. and about the infant vaccine also. So I think onus is on us to share the responsibility and have proper Indian data, because we are quite rich in such data. Thank you.
Thank you, Dr. Gayatri. I'm supposed to give the practice tip which was Dr. Shefali from Chandigarh was supposed to give. So I just want to close this session with just few lines, that the dream of every woman with rheumatic disease to have their own biological child. And the problem is that the main thing they require is a counseling during preconception stage. What happens, they all come once they are pregnant. So somehow what we require is a good communication with the treating rheumatologist and the gynecologist, and ask the patient to have a frequent visit to their rheumatologist, and the rheumatologist and the gynecologist should be doing the cross-talking, because patients do not understand. And I don't want to talk much, because Dr. Rohini has really covered the whole topic very nicely, and she has given take-home messages. And Gayatri has spoken about all the drugs which is to be given and contraindicated. So with this, I close this session, and thank you organizers and the audience for the patient listening. Thank you, IRA Indore.